Here we go. Okay, so we just go ahead and get started. Let's see. Okay, great. Well, welcome everyone to our January task force meeting for the League of Women Voters of Colorado's Healthcare Task Force. There's a lot going on in this arena. And so tonight we have with us Michelle Mills, who is the Chief Executive Officer of the Colorado Rural Health Center, which is a nonprofit state office of rural health and rural health association in Colorado. Michelle has had over 30 years of experience working with hospitals, clinics, home health agencies, emergency medical services, and long-term care facilities in our state. She participates in a number of advisory boards and is the recent past president of the National Rural Health Association. Michelle is also highly engaged with the governor and Medicaid on the Rural Health Transformation Grant and will chair the advisory committee. Michelle believes the future of rural health in Colorado can be summed up in one word, which is community. I like that. So take it away, Michelle, and welcome.
Well, thank you, Talia, and thank you, Beth, so much for the invite, and thank you all for joining tonight. Really appreciate it. So, as Talia was saying, I'm Michelle Mills. Just a little bit about me that kind of wasn't in my bio. We moved to Colorado when I was 12, and we moved from a suburb of Chicago to a very small rural town on the Eastern Plains called Elizabeth, Colorado. I live in Parker now. I've been here for 30, I don't know, 33 or 34 years.
Mhm.
Parker is by no means rural now. It was very rural when I moved here. It was about 5,000 people in the town or so. And then the town I grew up in had about little over 800 people and only about 5,000 in the whole county of Elbert. So I'm very familiar with rural and it's in my heart. And so when this job came open at the Colorado Rural Health Center, I was like so excited to be able to join. So I've been there for 16 years. But prior to that, I worked at the Quality Improvement Organization in our state, which used to be called CFMC. And so many of our rural hospital people have been there, and I worked with them in my past job, including my new job. So it's really great. So thanks for having me. So the Colorado Rural Health Center started in 1991. It started out of a coalition of folks meeting together that just wanted to talk about rural health. So those folks were like people in the state government, people, public health, the hospital association, really anybody that wanted to have a space to just talk about rural health. And so they met for several years. And then in 1990, the Federal Office of Rural Health Policy released a grant through HRSA that was called the State Office of Rural Health Grant. So our state said, "Hey, let's apply for that grant," and so
Mhm.
we did, and we started. This year is our 35th year. So,
Wow.
yay! We started with one employee and a like $35,000 grant. So we're much bigger than that. We have 18 staff now. So I think that's kind of big, but we ebb and flow between anywhere between kind of 15 and I think we have been as high as like 25 staff members or so. And that's mostly just based on the fact that we operate through grants. So when I say we are nonprofit state office of rural health, that means the governor recognizes us as state office of rural health, but we don't have any appropriations through the state. And so all of our funding really comes from grants and a very tiny percentage comes through membership. And we also serve as the Rural Health Association in Colorado too. So there's only two other states that are set up as nonprofits. They're South Carolina and Michigan. And
Hmm.
every other state office of rural health either operates out of state government or out of the major university within their state. So it's pretty unique.
Mhm.
Um, we serve all 53 rural counties in Colorado. That's split almost evenly. It's 28 rural and 24 frontier counties. And I think you are all from rural and frontier, so you know what that means. That I don't need.
Can you define it real quick?
Yeah, for sure. Happy to
Thank you.
do that. So Frontier is less than 6 people per square mile is what a frontier
Mm.
county is considered. And then a rural county is up to 50,000 people. So, and that is really a little bit over 809,000 people in our state live in either rural or frontier counties. In addition to us being state office of rural health, we have lots of education programs that we offer out to mostly hospitals and clinics. That's our primary target audience at the Rural Health Center, and quality programs. We have workforce programs as well that focus on recruitment and retention. We run the National Job Board in our state, which is great. And then we also have advocacy too. And I'll just capitalize by saying advocacy consists of one person plus me. So we don't have like a whole bunch of lobbyists that we pay and things of that nature. We just really have Kelly Erbzager, who's our director of policy, and myself as our policy voice. I don't lobby, Kelly does, so that's great, and she's registered lobbyist. But I would say most of what we do it falls in the line of advocacy versus lobbying. We do run a PLC, which is called a Policy and Legislative Committee, that is
Mm.
made up of all of our members, so all rural folks can join that. Usually we have around 30 or so, I would say, people on there representing the hospitals and the clinics. Our board is also an 8-member board, which is only made up of rural people as well. So, we're trying to stay true to our mission and our vision with that. Snapshot of rural health. So there's a nice picture of it, but I'm going to show you a visual.
There you go. Beautiful.
Thank you. I laugh. It's 146 pages now. So it is by no means a snapshot anymore of rural health. But back in 2008, when we started this, it was literally a one-page document until about 2012. And then we started really building it out. And the main intention of this snapshot of rural health is really to provide out a resource for our policymakers, for us, for anybody that cares about rural health, and it includes demographics, chronic disease, maternal health. You can see it's got a whole bunch of kind of cool infographics and stuff on there. And so our team spends a lot of time resourcing all that data and putting it together and compiling it. And we update it every single year. There's also about 50 or so maps included towards the back end of it as well that usually serve us pretty well and are helpful to when we're trying to talk about our message. So here's Kelly right here, and that's her presenting at the stage. And so she always takes a copy of this for our policymakers, both at the state and then at the federal level. We take this as well with us when we go. And like I said, grant writing and really a resource for all. So many of our hospital CEOs I know carry it around kind of like their Bible and say like, no, I got to have this. Let me flip through there to find XYZ. And people say, well, gosh, what about XYZ data is not in there? And I actually love it when somebody comes to us and says, hey, we don't have this data in here. And we're like, great, tell us where can we find that data and we will get it added in next year and stuff. So I take that as a positive, not as a negative that, it wasn't in there. And so I rather have people speak up and say what they need because I think that also shows that folks are using the information within it as well.
Mhm.
So, state advocacy. So, like I said, we have our members, which are rural hospitals and clinics. And so every year we reach out to them and we say, what are your highest priority areas? And from that, we drill down to usually about 10 different areas. I will say most of these have been the same issues for many, many years. They just kind of change positions sometimes year to year. And then that's ratified and approved by our board. So it's all rule developed. So in Colorado, we have 43 rural hospitals. The Hospital Association has this really great tool on their website that allows you to select the hospitals, and then it'll come out with all this great kind of financial data. And so I used it back last fall when we were working on the rural health transformation grant with the state and was able to calculate that our 43 rural hospitals bring in a little over $6 billion in economic value yearly to their communities. So that's
Mm.
huge. I think, nobody really realizes that. I think when you're talking about, one, two hospitals type of a thing, but I think that's a super important number to point out. And also, really being the largest employer too, they have a lot of jobs there in your communities as well. Of those 43 rural hospitals, 32 are considered critical access hospitals. So, a critical access hospital is a hospital that has 25 beds or less and is essentially paid a different way than a larger facility is paid. So, they're paid based on cost-based reimbursement. But with sequestration and many of other cuts, it's not actually 100% of what they're paid. And when I say 100%, I'm also meaning too that that is of allowable costs
Mhm.
as well. And so the other kind of really big piece of the criteria is to be a critical access hospital, you have to be 35 miles or more to the next facility or 15 miles or more mountainous terrain, or else you don't qualify. That's a huge qualification for that. And really those qualifiers are put in there because of the way they're paid.
Mm.
We have over 300 rural clinics in Colorado. 58 of those are considered a federally certified rural health clinic, which just means they're paid a little bit differently and have some different conditions of participation that they have to follow versus just a primary office that you would go into in a rural community. Many of those, I would say about three-quarters of those, I apologize, I didn't look up the exact number, are
Mm.
owned and operated by the rural hospital. So you guys likely know that, in rural, when I say, hospitals typically, top three employers, in most communities, the top employer, well, they also employ the physicians as well that work at the rural health clinics. And so that's not the case here in Denver. That's not how it works. They're all like physician practices, and then they have privileges at the hospital that they work under. So that is a very different way that rural works in terms of that relationship with the providers. There's also 77 federally qualified health centers or FQs. You might have heard the term of that. And then really important to note that there's 17 counties that don't have a hospital in Colorado. There's 19 that don't have a rural health clinic. And then there's 15 that don't
Mm.
have a federally qualified health center. So that's a lot of counties, that don't have access to healthcare directly close to them. And speaking of that, all right, so
Mm.
this map is kind of
There we go.
complicated and it's really little, and I apologize for that. But
That's okay. This is helpful.
yeah, if you can see the blue dots, that's essentially where the hospitals are located at.
Mm.
Um, the lighter the color, which is closest to the blue dot, is how close people are to the hospital. So people that live within that lightest color, which is 0 to 10 miles, they're 0 to 10 miles to the hospital.
Mm.
And then as the color gets darker and goes out, that's the further away they are from the rural hospital. So look up in Moffat County as an example, which is right up here, which is in the northwest. You can see hospitals here. If you live
Uh-huh.
over here, boy, it is taking you a long, long time to get over here to the hospital for care. So that's why it's a big deal. And I say that's not only why it's a big deal, but it's a part of why we're trying to focus on explaining the story of rural hospitals, the care they provide, the community that they go and support, right? Because if this hospital closes, oh my goodness, where are people going to
Mhm.
go? They're going to go here, here, or here. I mean, total other counties they are going to have to go to seek care. So while this says here, it's like average distance is 10.7 miles. In some cases, we have very large distances that people have to travel. So it's a big deal. And I love that our data person, Greg, created this because I think it's a really nice visual for explaining that to people that maybe don't understand the geography of our state and just how vast we are.
Mm.
And then Medicare and Medicaid.
You
So
go ahead.
again, these numbers are super little, but if you download our snapshot of rural health, you'll be able to see it with, holding it up a little closer. We can read the numbers. But essentially, the darker the color, the more patients they have in their counties that are on either Medicare or Medicaid insurance.
Mm.
So way down here in Castilla County, they've got little over 88% of their patients are on Medicare and Medicaid. The reason why that's a big deal is because Medicare and Medicaid tend to not pay as well as insurance companies, such as like United, maybe, or Aetna or Cigna or one of the bigger companies that most people that are employed have health insurance like through and things of that nature. So what that means to the bottom line of the rural either hospital or clinic is that they're not getting paid what it costs to actually provide the care to that patient. So when I get in just a few slides, you'll see some of the impact financially of what that means for them.
Mm.
So nationally, we've had about 200 hospitals close since
Mm.
2010. I looked this number up the other day, so who knows, it may be higher than that now. We get this data from the National Rural Health Association, who the data is comes from Chartis, which is a group that comes up with all of that data from the rural hospitals nationally. We're lucky. I mean, in Colorado, we have not had a rural hospital close. And I mean, really, like I knock on wood here because um, that is not true in many, many states. Um, a part of that I think can be attributed to the fact that we expanded Medicaid in our state. While Medicaid may not be the best payer, it's better to have some payer than
Mm,
no payer type of a thing. We have 49 rural hospital, or 49% of our rural hospitals are operating in the red, so that's 21 of the 43 with kind of that average operating margin of a negative 3.4%. So they're always operating in the red.
mm,
Of that 21 rural hospitals operating in the red, 19 of those are critical access hospitals. So those very small hospitals that are located in Colorado. So that's 59%, which
mm,
is um, which is a lot. And it's been that way since I I can't remember. I think we've been as high, I feel like maybe 2018 or 2019, we were as high as something like 24 of our rural hospitals operating in the red. So that number is usually pulled from this data the Chartist pulls, and they pull that from the cost report data that the hospitals submit, and it's based on third quarter of the previous year. That's how they get that. So they update it every single year. And so when you hear Alan Morgan, the CEO of the National Rural Health Association, quoted hospitals, this is the data that they use for that. This I just show you not to depress you, um, but having days cash on hand is a huge deal, and many of our rural facilities operate with a very small margin of days cash on hand. So while we say here 23% of the CAs are operating below 80 days cash on hand. I mean, I know some of our facilities that have less than 30 days cash on hand, which is not great, especially in the environment of cuts that are coming up and that we're facing. So this slide is just kind of demonstrating with some data, just some of the additional challenges that folks have financially to sustain. And here, I just want to beat it into a little bit more. So,
yeah,
45% of our critical access hospitals had, uncompensated care.
mm,
Uncompensated care essentially means when somebody comes in and they can't pay their bill, that results in the hospital having to like write those costs off. Well, it's easy for not easy, that's the wrong word. It is more manageable for hospitals that are bigger and actually have a profit to eat some of those costs than it is for our facilities to have rising uncompensated care when they're already operating in the red with negative margins. And we also have a large turnover of CEOs.
mm,
Last year we had 22% of our rural CEOs turnover. And, that's for a whole variety of reasons that I'm sure you can
mhm.
think of in your head.
Yeah, absolutely.
Yep. Workforce. So I talked a little bit early, healthcare is one of the top three industries in
Mm,
in rural, and often the hospital's the largest employer. So it's a big deal that we keep rural hospitals open for jobs. Um,
mm,
we also are facing physician shortages. This is a crazy number, but
mm,
we would need 75% more physicians to have the same amount of access to providers as urban.
Wow.
And that number is way worse if you start looking at specialty care. So, for a pulmonologist, as an example, we would need 323% more pulmonologists, 162% more psychiatrists.
Mm,
So again, when you're talking about numbers like that, what that really means is that, if you're a person living in rural and you need access to that type of specialty care, usually you're driving hours and hours away from your home to seek that care. And I've got in a couple of slides later, I'll show you a little bit of some of the kind of estimated cost breakdown of that. But, you're talking about, maybe you have to get childcare, maybe you don't have a car and you need somebody, to drive you, maybe you have to take the day off from work. There's a whole,
mhm,
source of problems that that leads to. And then we know too, we tend to have ranchers that, I'm just stereotyping a little bit here, but, that will just say, I'm not doing it, right? Like I
mhm,
can't be gone that long from the ranch. I have a job to do. So I'm just going to forgo care kind of a thing. And,
mhm,
that's the absolute opposite of what we want people to do. And then we face, shortages for nurses as well. So same scenario, 29% more RNs are needed in rural to equal urban access, and 59% more PAs or physician assistants are
mm,
needed as well. So a lot of workforce challenges.
mhm,
Um, Here, this is also describing, in addition to just physically not having enough people, there was this workforce survey that was done last year, and you can see kind of right in this area that physicians are reporting an increase of
mm,
142% burnout. Nurses are reporting an increase of 121% burn out, and that doesn't bode well for us trying to find more providers to come and live and practice and be part of our communities in rural. So somehow we've got to figure out this problem and help trying to solve it. But people are feeling kind of overworked and and understaffed, and rightfully so, right? Like, I mean, sometimes it will take a community depending on where you live. So obviously mountainous communities have a little easier time recruiting
mm,
people, because it's by some, it's seen as a nicer lifestyle. Oh, I can go skiing, I can go hike in the mountains, where on the Eastern Plains, we sometimes have a harder problem doing that because we don't have those types of amenities. We have different amenities, but not the same. So, it can take upwards of a year or so to recruit a physician to a community.
Can
Yeah,
I interrupt for a second?
yeah.
So I'm sitting here in Gunnison, and Western Colorado University is here,
Hmm.
and they have just developed a brand new nursing program to
Great.
focus on rural healthcare,
Yeah,
and
I
to
love
get
that.
folks to stay in the rural communities once they've graduated.
Yeah, they say that's one of the biggest drivers, right? Like if you
Yeah.
have experience of working in rural, and or you grew up and lived in rural and you want that lifestyle, and quite honestly, that's the people we want, right? That's the people we want to recruit, is people that want to be a part of our communities, and they want to be there. And I was speaking with a doc yesterday from Sterling, and I've known him for a long, long time, and we were chatting just about some of these challenges, and just how hard it is to find people, and so I think any kind of creative, like grow your own programs, partnerships with,
Mm-hmm.
colleges, even, I mean, even partnerships, I think, going down to the level of, working with elementary and middle school and high school and getting people exposed to, gosh, this is, what an exciting career in healthcare could be
Mm-hmm.
like. Tuesday, I was also out at Lincoln Health, which is out in Hugo, Colorado, and we were meeting a group of CEOs and some docs. We're meeting with Senator Hickenlooper and the CEO of Lincoln Health. His name's Kevin Stansberry. He had his granddaughter there that I don't know, she was like 9 or 10, and she was just sitting, at the table or whatever and listening intently. And I was like, that's amazing, right? But that's the
Mm-hmm.
age you have to start to,
Truly. Yep.
introduce, yeah, kids to, right?
Yep. That's awesome.
Yeah. Um, so here, I'm probably not telling you anything you don't know, but
Mm-hmm.
rural, our patients tend to be, older, sicker, and poorer than urban. This is a whole part of the problem of why we operate in the red, right? So we're taking patients that are more challenged, potentially than urban. So we don't have as good payer mix in terms of insurance companies. And then, costs continue to rise, not only for us personally, but for businesses, like the hospitals, their costs of goods and supplies and stuff continue to go up. Us as people continue to have expectation that, our wages are going to go up, that we're going to continue to have good benefits. But yet the insurance companies' reimbursement rates are not going up and they're not tracking along with those expenses. So, I try to explain it to my staff by saying, if you have $10 in your checking account and you're spending 15, you don't have 15 to spend. And
Yeah.
this is this is kind of what's happening in terms of our rural facilities is just, things are costing more than they're getting reimbursed for. And so it's creating this huge disparity. And then we have a number of, not all, but we have a number of rural facilities that are aging and they need to be upgraded. And and it it sounds kind of silly in some ways when you say it like this, but like if you have a super old hospital, let's say like built in the 50s or 60s, you know,
Mm-hmm.
your wiring probably isn't, 2026 wiring type of a thing. So if you want to buy the latest and greatest MRI machine or electronic medical record or whatever, you have to be able to use that within your facility. Well, if your wiring is not up to date and not able to handle the technology, how do you upgrade? And then when you don't upgrade, those things lead to outmigration, right? Because patients are maybe poached to other communities by like, oh gosh, look at this hospital over here has, the latest and the greatest shiny
Mm-hmm.
kind of equipment, and I want to go there. And, and I've been in all sorts of hospitals where, the ceiling is only like this high from the top of my head to facilities that look like you're walking into a ski lodge. So, we have all sorts. But the simple fact here is I'm trying to say is that there isn't capital monies available for folks like there used to be able to afford to, replace your facility. It's very, very costly. And then, of course, since the pandemic costs for building and supplies have continued to rise too, which is just continuing to widen that gap as well.
Mm-hmm.
Okay, so this is what I was talking about for this patient
Mm-hmm.
case study. So I've just talked a whole lot about the hospitals, challenges, and problems. So let's not forget the patient, right? Because that's why
It's a
we're
good
here,
idea.
is to actually serve the people. So when we are asking a patient to leave their community, one day out of their community is costing them just a
Oh,
little
gosh.
over $700
Wow.
one day.
Hmm.
But it's saving the insurance company close to $600 a
Hmm.
day. So, your insurance company might say something like, oh, you have to have that x-ray taken and it costs, $20 at your rural hospital. So I don't want you to go to your rural hospital. I'm only authorizing you to go to Grand Junction for that,
Hmm.
and because it only costs $5. Well, yeah, you're right. Maybe that only costs $5, but it's costing me $700 to make
Yep.
that trip. And that's even if you choose as a patient, right, to
Mhm.
make that choice of doing that. So I love this. We put this together just to be able to clearly articulate kind of that story when we were talking to policymakers, because sometimes I feel like they don't get it. So
And these numbers are very reasonable, like a
great.
mileage reimbursement or 1 day of lost wages of $234 is not, it's very, what do I want to say, realistic, I guess.
Yeah. Yeah,
Yeah.
absolutely. Yeah. So what are we doing?
Here
So
we go. This is what we need to know. Yeah.
that's right. So we get to partner with a whole bunch of people, which I love. So we do this thing at our work that we call Strength Finders, which is based on Gallup, and it tells you kind of what your top strengths are. So my top strength is called Woo, which essentially means I love to talk to people and I love to make connections and have relationships with people. So I always say, like, it's great. I get paid to talk, so I love that. And so we work with the National Rural Health Association. We work with the National Association of State Offices of Rural Health. We work with CMS. We work with HHS. We work with Federal Office of Rural Health Policy. We work with um, the National Rural Health Clinic group. There's so many kind of federal leaders that we're just very fortunate to work with. Last year, I was the president of the National Rural Health Association. It was really like such an honor, I'll say, to be able to serve in that role. And it was also like blowing my mind how crazy it was of a year. But through that offered our organization through me a lot of opportunities to be able to meet with folks that I would never be able to have access to without NRHA to do that. So, for example, we got to sit down and meet with RFK Jr. and we got to, sit down and talk about things that are rural health, and help him understand why it was important for his organization, HHS, to be able to continue to support rural health. One of the statistics that I spouted off during that meeting for my portion of it was to represent the HRSA grants that our offices receive, which is the State Office of Rural Health Grant, and then the Rural Hospital Flexibility Grant, and then the Small Rural Hospital Improvement Grant, which all go to support rural hospitals and clinics across our state. But essentially, if you add all those up together for each facility, it's about $80,000 roughly in technical assistance. And that's a person, right? Like that's a
Mhm.
FTE at facilities. So it's a big deal. So even though, we're small, I always like to say, we're mighty. There's one of us in every state, and people are really trying to do great work to offer out technical assistance and resources and education for our rural facilities that they're low staff. They don't have a whole lot of
Mhm.
extra people. So this is some of what NRHA focuses on. So these ones that I bolded are really the big categories, investing in a strong rural safety net, reducing rural healthcare workforce shortages, and building rural health opportunities. And I won't go through and
Mhm.
read some of those programs, but when you look at bills and policy that NRHA supports, they're really all in the vein of those kind of three top policy priority areas, which is really fabulous. And I'll say one of the problems we face a little bit, and why like you'll tend to see like similar policy priorities year after year, is because at the end of every year, whatever kind of bills, folks have negotiated with different policymakers, if those bills don't get passed, all of that work just gets scrapped and they have to start that process over again. And so it's easier process to start over when people are the same. But when you have elections and people turn over, then you have to get new buy-in from people. You have to re-present the information. You have to rewrite a bill. And then, you have to get the attention of Congress, which we know
Mhm.
is very difficult. And you need to get them to pass something. And so that's why you'll tend to see many of these things have been focuses for several years, because it's just really, really hard to get Congress to pass something, even if they say they're supportive of it and bipartisan support of rural health. Um, so anyways, NRHA's website is really a wealth of knowledge. They have a whole tab under there that is their advocacy tab. And, I would definitely encourage you, if you want to learn more, to go out and reach and do that. So each year in February, NRHA hosts what they call a policy institute, and it's where they bring a whole bunch of people like me and others together throughout the United States, and we descend on DC. And so we have a little bit of a conference, and we get to hear from different policymakers in different states, which is always kind of exciting to hear their take, especially when they're from a different state than your own. And then we all kind of descend on the hill for a day where we get to actually sit down and meet with our policymakers. So when Kelly and I first started going, I feel like it was like Kelly and I. Last year
Mhm.
we had like 17 people. It was crazy. And crazy in a good way, I mean. And
Mhm.
there was usually you get, 20, 30 minutes max with these people. And so, can you imagine trying to wrangle in 17 people who all want to get their points in, about what to say to their policymakers? So Kelly takes that on, and she does an awesome job of really setting up those meetings for us. She makes sure we're going where we need to go, and it's a really fun day. And most importantly, last year when I was president and I was speaking to the group, I said something along the lines of like, I know it can feel intimidating, right, to go and meet with these people. And gosh, I certainly remember the first time, I went and made visits on the Hill. This year will be like my 16th year. So I'm not afraid anymore, which is great. But I always tell people, I'm like, remember, you're an expert in your rural health. They aren't. You know more than they do. So you're there just to tell them your story, to educate them. And so I would just say, if any of you ever have the opportunity to do that, either, at state or federal level, boy, I really encourage you. It's just
Mhm.
kind of a once in a lifetime experience, and it really lets you kind of see the inner workings that I feel like you never kind of get to see. And so it's a pretty exciting part of what we do and our job. And I really feel like we get to make a difference in, carrying those points forward for our rural communities. So here's us, for some of us from last year,
Nice.
when we went. And so last year we had 23 meetings. That was a lot.
That's a
Like,
lot of meetings.
yeah, usually Kelly and I go once a year. Well, because I was NRHA president, I went a lot. So in addition to meeting with RFK Jr., I had the chance to meet also with a small group of folks with Dr. Oz, which was great. And, be able to just kind of tout some of the things that, we wanted to do with some of those rural transformation funds in Colorado. And so I think he had an opportunity to hear from us. Now, did it come out the way we
Mm,
wanted? No,
no.
absolutely not. But but at least, we had the opportunity to sit there, and I really feel like without me having sat in that seat, I wouldn't have had that opportunity. So last year we made a huge push. So we wrote letters to the federal delegation. We wrote emails, we had action alerts, we had lots
Good.
of kind of news media, um, lots of social media, and, really just trying to fight for all things rural. And
Mhm.
so it was great. It was stressful, but it was great.
Mm,
Okay, so, we're also facing this like terrible issue of
mhm,
$850 million deficit in the state budget. So since 2018, the Medicaid spending has risen by like 60%, which is crazy, right? And it's just not sustainable. The costs are rising. We have Tabor, the Taxpayers Bill of Rights, which, limits what we can do and how much money the state can keep. And so that creates an imbalance in terms of, how to pay for things. So where Medicaid is roughly a third of the state's overall general spending. And I will say, Medicaid put in some programs during the pandemic with one-time funds, and the
mm,
states continued to like fund it. Well, that's great when you have a
mhm,
surplus of money, right? But when you don't, then now you're
mm,
seeing what we saw last year, the problems, increasingly worse this year as well. Um, they're saying that, the state's increase in Medicaid is, long-term care is a driver because we're an aging state, and also saying, expenses related to behavioral health. So there's a report that's supposed to be coming out from this organization called Manat in February. So I'll be curious to kind of read the report to see what they concluded kind of beyond what this says here.
do you know, so if a third of our state budget is spent on Medicaid, is that completely different from other rural dominated states?
Yeah, yeah. I mean, we're much, much higher Medicaid spend than many states. So, I think that's a part of the problem with the argument when you hear, folks say, well, we just have to spend that or we just have to spend that. But, at some point you just don't have the money to spend.
Right.
So we've got to try to figure out, how do we solve like
Mhm.
this problem? We can't spend the entire state budget only on Medicaid, right?
Right. Right.
Um, so these are some of the options that have been floated thus far is that we could dip below our required statutory 15% reserve and go an additional 2%, but that's only solving about a third of the 850 million issues. So there's still a lot of lot of
Mhm,
cuts.
mhm.
Um, and then, I put this here kind of as like a joke, clawing back the 92 million or whatever, because, HIGPUV over expended money. So what are we going to do about it? Well, one of the things that's been proposed is that every provider get, a 0.75% rate reduction. Well, nobody's in favor of that, right? Because we're already
Nope.
operating in the red. Like, come on, what
Hmm.
are you talking about? They're talking about this kind of cost control for non-emergent medical transit, or, what they're kind of coining, we're going to find more, waste, fraud, and abuse within the program, expanding RAC audits. So those are audits that, they conduct on providers to make sure they're doing what they're supposed to do. So expanding those out. We already have a larger number of years that we do a look back for than other states. So folks aren't in favor of that either. So we'll see what happens. It's going to be a wild ride, I feel like, this year.
Hmm.
Uh, I won't read through all of these, but boy, we are facing a lot of losses coming up. So, loss of subsidies, loss of Medicaid, uncompensated care is going to grow. The provider tax payment, the amount we're able to claim is going from 6% to 3%, so cut in half. That's going to be a huge loss of funding for folks. We're waiting to see, will Congress actually pass a budget? I don't know, or are they just going to continue to pass a continuing resolution? Medicare Advantage for our folks that usually results in a lot of denials. They typically will cut rural hospitals out of the network, forcing patients to leave their communities for care. Redetermination, which means patients will have to attest that they still qualify for Medicaid every 6 months versus every year. So what that is likely going to do is going to have more people fall off of Medicaid because they just simply don't want to go through the process. Oh, and then our state has to figure out how they're going to track Medicaid requirements, which they're estimating is going to cost like 150 million to build that system.
Terrific.
Yeah. Rural health transformation. This was the $50 billion grant that was put into HR 1, the
Hmm.
big bill that was passed last year. So every state was asked to apply for 200 million. So
Hmm.
we did put it together. There was a lot of stakeholdering, but at the end of the day, the application had to be built within like 6 weeks. It was crazy. Um, so Colorado was awarded just a little over the 200 million. Right now, Medicaid is in the process of working with CMS to come up with contracts for that, to put that in place. Um, these are the areas that the state applied for, and then kind of further down in the slides, I have a little area that you can go to find more regular up-to-date information. But CMS is pretty prescriptive of what you could apply for and what you couldn't apply for. So, for example, you couldn't apply to have this replace the cuts in Medicaid that were put into the bill. It had to be transformation or kind of new work.
That's too bad.
So it had to be under, kind of this chronic disease and prevention, under building new things, creating networks, strengthening the rural health delivery system, sustaining
Mm.
operations, building a healthy workforce, um, uh, and so on and so forth. The whole application is out on this website right here. So I encourage you to go through and look at that. Um, right at the moment, there is, I think today was the last day that Medicaid put out a memo that said, hey, we're going to form this advisory committee, and it's going to consist of XYZ type of seats. And
Mm-hmm.
so one of those types of seats is is a person that lives in a rural community. One of those types of seats is a physician or a nurse. One of those types of seats is a rural clinic. I think four types of those seats are rural CEOs or CFOs or quality folks at the rural hospital. And so that application should be coming out, I hope, next week. And so I definitely, if you're interested in getting involved, look and, maybe it's something you want to apply to be on and lend your voice to those efforts. And then I will be chairing that committee. I don't know that I want to chair that committee, but I was voluntold that I will be chairing that committee. So,
Yeah.
yeah, so that'll be great.
Michelle, we only have a few minutes left and there's some pretty heady questions in the chat. So
Okay.
okay, great. Let's see. First question, do you know how many and what type of services may have been cut by rural hospitals just in the last 1 to 2 years?
Yeah, OB, I would say, is the biggest service line that is being cut. And when folks really start to struggle, that's the one that goes away because it's very expensive and it's
Hmm.
very hard to find physicians to fill those roles.
Hmm. Okay. Let's see. Jeff wants to know, could you please talk a bit about the relationships between financially viable front range hospitals and poorly reimbursed rural hospitals? As an example, we see here in Gunnison, UC Health supporting Epic, which is the electronic patient,
Yep.
yep, for rural hospitals. Do these relationships and partnerships have a future, or are rural hospitals seen as poor financial partners?
Um, yes. Yes.
Both. Okay. Yes to all of the above.
Yes to both. Yes, I think there's great opportunities to partner while still remaining independent, rural facility, if that's what makes the best sense for you and your community. And I think just what you've just said in terms of like Epic electronic medical record, a lot of the big urban facilities will offer their version of that rural hospitals can buy for a discounted price. But when I
Mhm.
say a discounted price, you're still talking like $1 million. I mean, it's
Yeah.
very, very expensive, but I always laugh because I say it's kind of like your phone, right? Like you have to
Mhm.
replace it every now and then, and it keeps getting more and
That's
more expensive.
right. Right. Okay. Let's see. High spend on Medicaid in Colorado. This is the topic area. Do you have any statistics on funds spent on cost of care, payment to providers and facilities versus quality improvement or demonstrations of non-direct patient care?
I don't have specific data on that, but I will say that there's a program that's going on that we call the Rural Connectivity Program, which is a partnership with Carina Health, which has developed a dashboard and Medicaid funds through federal funds that come from CMS, Center for Medicare and Medicaid Services, and it brings in all payer claims database. It brings in the health information exchange contexture data into that as well, and it populates dashboards that folks can
Mm,
look at things like out migration, how many folks they have that have diabetes that are within control, things of that nature. The missing piece to that is the connection of the electronic medical record to that database. And so I'm hopeful at some point there's going to be some monies available at either, state or federal level that we can help fund those connections.
awesome. And then final question. Do you know how the funds will trickle down to each county or rural clinic and facility? Is it predetermined or do counties and facilities or clinics have to apply for those funds every single year?
Great question. Not predetermined. Folks are going to have to apply for them. I don't know if it's going to be yearly or if it's going to be like, hey, you apply once for the entire 5 years. But the great thing is that advisory committee is going to get to help make those decisions, which I think is really wonderful.
Cool. Okay. And then Suzanne is asking, do you have data about what percentage of people living in rural areas are covered under Medicaid, Medicare, or commercial or insurance or uninsured folks? Just wondering about the impact on Medicaid cuts Medicaid cuts on patients, hospitals, and clinics.
Yes, absolutely. If you download our snapshot of rural health, which you can find
Mhm.
on your website
Which
at
I did. It's real easy to do.
yep,
Yep.
coruralhealth.org, and you
Yep.
just download it, and it's got lots of maps and information in about that. And then there's a web page that our associate director of outreach created on our website where we're going to try to continually have updated data about, who's kind of falling off of Medicaid and uncompensated care, how that may be increasing for folks as well. But right now, we're in this like, oh gosh, we need the data piece of that. But there is some really great data in the snapshot.
Okay, cool. And then just lastly, since we are a task force, do you have any suggestions on what we can do to improve the situation in our rural and frontier counties?
Oh my gosh, yes. Well, thank you first for being interested in healthcare in your communities. And I definitely encourage you to, try to sit down and, meet as a committee if you can, with the hospital leaders there and with the clinic leaders. And, I always find it helpful if you can try to collaborate with people and come to solutions that make the best sense for each of your communities because that's going to be different for every community. It's going to be different for Gunnison than it is for, Hugo than it is for, any other rural
Mhm.
community. And so I just really encourage you to sit down and make your voice heard and, and get involved.
Well, and locally in Gunnison, we do have a small group of enthusiastic folks who are doing just that. So
Yeah,
hopefully we'll be able to make a difference.
I bet you will.
Yeah, thank you very much. I think it's time to close. Unless anyone has a last minute question, you could just shout it out if you like. But thank you, Michelle. This was very depressingly informative.
I know, I'm sorry.
I'm sorry about that. You're so cheerful and upbeat, so you're the right person for the job.
Good. Well, thanks. Yeah, so I'm leaving you with a picture of my dog,
That's
Poppy.
that's perfect. And is
And
that you on your
then
wedding?
that's a picture of my daughter and her husband.
Oh,
We got
oh, that's
married back in August in Sedalia. So,
that's great.
so
Good. We got to
yeah,
remember all those good things, right?
that's right. It's got to have some good stuff.
Yeah, thanks. And I'll have the recording along with the chat emailed out to everybody who participated in this or registered as well. So thank you everyone for attending, and it's time for dinner. Thanks.
Take care.
Thanks, Michelle.
Thanks.
It's been
Bye.
terrific. I really appreciate it. Thank you.
Absolutely. Take care.
You too.